After a long hiatus of the Psych Commute, I am back, and today I wanted to talk about a decision tool that I sometimes use in the heat of the moment, and I'll give two versions of it. A simple version called DEAL, DEAL, and a little bit more complicated version called DEAPL, that's DEAPL. And these are acronyms, and they're used to help you make clinical decisions, oftentimes somewhat high stakes clinical decisions under uncertainty. So let me give an example case of a tricky situation I had in the inpatient setting. So I had a patient who was severely behaviorally dysregulated. There was a behavioral code called, and the patient had to be restrained as he was both harming himself and attacking other patients. And then the patient had what appeared to be a seizure-like episode. And so right after a behavioral code was called, there was a code blue, a medical code for the convulsions and loss of consciousness. We did all the things. We tracked the duration of his loss of consciousness. We checked a glucose, normal, did repeated vital signs, normal. Now we're a freestanding psychiatric hospital, so we don't have stat labs. We don't have neurology consultations or EEG. All we have are glucose checks, vital signs, our physical exam, and an EKG machine. So in the setting of a medical code, really our decision is this a true emergency that needs to be sent out via ambulance to an emergency room? Or is this not a real emergency and it's something that we can manage in the hospital? I mean, so that gets tricky because you don't have all the information you need. And so sometimes the decision is to send them out to the ED just to do the appropriate tests that might reveal whether or not this is emergency or not. But there's risk to sending a psychiatric patient out too. There's the risk that, especially in the case of someone who's very behaviorally dysregulated, that they could injure themselves or injure somebody else in transit. And so sometimes sending them out, the risks of that really need to be weighed against the probability of there being a true severe medical issue. So anyways, in this situation, that was the problem at hand. We had a severely behaviorally dysregulated person, actively a risk of harm to themselves and others. Now they're having convulsive activity. What should we do? Now, in this case, the patient reoriented very quickly after about 2 minutes. And so either the seizure self-terminated or it wasn't a real seizure, and it was a psychogenic non-epileptic attack, sometimes also called a dissociative attack. So that's where I use this decision tool, the longer version being DEAPL, as I said, DEAPL. So the D stands for define and or diagnose the problem. So that's just where you take a step back. Okay, what is the situation here and what could be causing the problem? So in this case, the context is a behaviorally dysregulated patient now having seizure-like activity. What could be causing this? Well, it's either a real seizure or it's not a real seizure, and it's just a dissociative attack, right? Those are basically the options. It could be a syncopal episode, convulsive syncope. I suppose the patient could have just been feigning it, could have been totally made up. But there's not too many options here as to what could be going on. Only a real seizure and I guess convulsive syncope would be medically concerning and may require medical treatment. So that's the situation. That's the problem. That's the sort of differential diagnosis of the problem. That's the D of DEAPL. Then moving on to E. E stands for enumerate the options or enumerate the choices. So an enumerate is just a fancy word for list. So list, what are all the options? What are all the possible choices that I could make in this situation? Well, in this situation, again, given that I work in a freestanding psychiatric hospital, I really have only two options. I either keep the patient at the hospital and try to manage the situation there. We do have the option of consulting an internal medicine doctor, but that's not a stat consult. And again, they have the same tools that the psychiatrists have in terms of labs that are only sent out and we'll get the results the next day at best. We've got a decent pharmacy. We've got medications to treat medical conditions as well, of course. So either keep the patient on the unit and manage them in the psych hospital, or we send them out to the emergency room. So those are the options. Then moving on to the A in DEAPL. So the DEA are the same in the longer version DEAPL as they are in the shorter version DEAL, DEAL. But the A stands for ask yourself if you have enough information to make the decision. Or a shorter way of saying that would be assess informational adequacy. So again, do you have enough information to even make the right decision here? And by implication, if you don't, then can you get more information, or how can you get more information? So in this case, there wasn't quite enough information to be confident about which decision was the best call. And so we did some chart review and we found out that this patient has had similar episodes, similar convulsive-like episodes in the past. And at least some doctor had suggested that they were psychogenic, although this person had never had any proper workup, no EEG, not even a spot EEG. So that lended some weight in addition to just the presentation of convulsions that made us think this is more likely to be a psychogenic non-epileptic attack as opposed to a true epileptic type seizure. So moving on to the P in the longer version, and DP stands for predict or project the probable outcomes of each decision, of each choice, of each option. So if we keep the patient there, what is likely to happen? Well, worst case scenario is they have another seizure-like episode, right? And then we're back at square one of trying to decide what to do. In the very worst case, if they have a seizure episode, what could go wrong? I mean, seizures in themselves are generally not deadly. There are rare cases of sudden death due to seizures. I believe that's called SUDEP, or sudden unexplained death due to epilepsy. But that's pretty rare, and we're leaning more toward this not being true epileptic seizures. So that's kind of the worst case. Of course, this person could have fallen if it's a true seizure and suffered some injury. But from the chart review, we didn't see any history of that. What else could happen if we keep them there? Well, in the best case, they don't have any more episodes. We are able to successfully treat their acute psychiatric issue and send them for outpatient care. The other option is we send them to the emergency room. So what's the worst case in that scenario? Well, they're currently extremely behaviorally dysregulated. They could significantly injure themselves or staff during transport. They could potentially elope during transport, and something really bad could happen to them. So that's not good. And what's likely to happen when they get to the ER, right? They're not currently having an episode. Unless they have another episode while they're in the ER, and the ER is able to put on a spot EEG during the episode somehow, they're probably not going to be able to figure out the diagnosis there, right? This is in terms of a diagnosis to know if these are true epileptic seizures or not. They'd have to undergo long-term monitoring. So the best case scenario in the ED is they're going to do some blood tests. Maybe they'll do a CT scan and kind of rule out acute issues and then send them right back. And I should mention, this is a person who's had head imaging fairly recently for other reasons. So those are kind of the likely scenarios with each option. And then the L in DEAPL stands for limit your downside. And so this is just a heuristic. A general rule of thumb is the best option is generally going to be the one that limits your worst case scenario, limits your downside. And so in this case, the worst case scenario with transferring them to the ED is generally worse. The downside there is worse than keeping them in the hospital. And so I decided to just keep them in the hospital. And in the end, it turned out fine. We stabilized them psychiatrically and they were able to discharge. DEAL, DEAL, is just a shorter version of that. So that's just define or diagnose the problem, sort of a differential diagnosis. Enumerate the options. Again, that's just a fancy word for list the options. Ask yourself if you have enough information to make a good decision. That's assess informational adequacy. And then L for limit your downside. So that you're just removing the project or predict the likely outcomes. DEAL is a little bit easier to remember, but DEAPL is a little bit more thorough. So anyways, I think that's just a useful kind of decision tool to keep in your back pocket if you're in tricky situations like that and you don't have a ton of time to sit there and think about it. It's a quick system to run through your head. So hopefully that was helpful, and take care.